everyone. This is a case I have recently seen in my casualty that he was a 39-year-old male. He sustained a dog bite, especially in the hands and fingers. You can clearly see the location of this dog bite. Okay, see. And on examination, the primary survey, the patient was alert, oriented to time, person, place, and person. And the airway, breathing, circulations, everything was within the normal limits. The disability part, the GCS was 15 by 15, and the pupils was bilaterally reactive to light. When I noticed here, the wound was around 2 to 1 centimeter size. Active bleeding was initially present, but after giving compression, the bleeding stopped. So looking for the adjuncts, when we received the patient, there was bleeding. So what we done was we applied compression and we inserted a cannula. So we also given a Tranaxa injection 1 ampule. Okay. So next we went for a pain management. Pain management means the patient was a bit painful in the dog bite side. So we given an injection of 1 gram of paracetamol IV infusion. Then about the wound care, one thing, for a pain management, if the pain was severe, you should have go for a ring block on the near to the web space. We give a ring block so that the pain won't be felt near the fingers. The wound management, important thing you should be noted is that uh, better you avoid suturing. Okay, first you thoroughly wash the wound with normal saline, tincture iodine, betadine, and it for 15 minutes, at least for 15 minutes, so that the dirts, everything will be cleared out. Next, you give a TT injection, that is 0.5 ml IM stat at small TT injection you give, because it's just a foreign bite. Okay, so a question arises there: what all bites are prone for tetanus? There are high risk and low risk. You see, the dog bite, the cat bite, fox, fork, bat. These are all high risk bites where you should take tetanus. But rodents like a rat, mouse, all those things are low risk. If possible, you can take. If at all, not at all. If there is not available, no problem. Okay. So here I am categorizing the wound. Here, when I see here the patient wound itself, it's a class 3 wound. Why I am telling it's a class 3 wound is that the category 1 means just touching or feeding animal, licking on the intact skin, contact with intact skin with secretions or excretion of a rabid animal or person. So in such cases, there is no post-exposure prophylaxis required. Okay. The next is the category 2, nibbling over uncovered skin, minor scratch or abrasion without bleeding. In such case, we need some vaccination. We need vaccination. Okay. Third is the category wound where there is single or multiple transdermal bite or scratches, licks, broken skin, contamination of mucosal membrane with saliva from licks and exposure to bats. We already told. So in such cases, we not only vaccine is enough, we need immunoglobulins. Okay, and that too within 7 days from the date of bite. So as we told before, the suturing is better avoided. Why? It can get infected. But if the wound is in a phase for cosmetic purpose, we can suture. Ideally, we don't suture, but in case if it is for the cosmetic purpose, in phase, you can suture. Even though we suture, we should not use any tight suturing or a different subcuticular or such like suturing. You can use a simple suture in case if there is abscess forming, we can remove it earlier, at the earliest. Okay. Contraindication for suturing, we know in punctured wound, crushed wound, if the bite occurred and it is taken after 12 hours, the patient presented after the bite, don't need to suture. If the patient come after 2 to 3 days without any infection, then we can look for suturing. Next comes that if at all you suture, you use only simple suture. I just mentioned you before that you use only simple suture. Why? Because in case any abscess or infection occurs, you can remove it easily. That's why. Next is high risk bite sites are the face, hand, chest, and genitalia because it may reach the brain very fast and very vascular regions. We told that this is a class 3 bite. So we use vaccinations, immunoglobulin, active vaccinations and passive vaccinations. In active vaccinations, we use two types of vaccine, that is intramuscular rabies vaccine and intradermal rabies vaccine. Okay. So those are these vaccines, that is Eurorab and Rabipur. These are the two vaccine which can be used intradermally and intramuscularly. Okay. We have intradermal vaccine. You see that how the intradermal vaccines are taken. You see that just in the deltoid, just underneath the skin. You should see the blood like this. This is the ideal intradermal vaccination. So intradermal vaccine, you think like this one. Since it is intradermal, you 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 remember the D here. You D dermal D for double. So you should take in dual sites, two sites. That is, you take a zero point 0.1 ml in one syringe and you administer in two sites. That is 2-2-2-0-2 regime. 2-2-2-0-2 regime, mostly on the deltoid, and you can also use in the suprascapular area. Okay, both deltoid. And what all days you should take that vaccination is 0, 3, 7, and 28. That is 5 days. Sorry, 4 days. 0, 3, 7, 28, 4 days. That is the days of vaccination, two sites and 0.1 ml. Then comes intramuscular. Intramuscular, there is only one site. In intradermal, we remember D, that is dual double. Here, intramuscular, single site, we took 1, 1, 1, 1, 1. That is 0, 3, 14, 28. In previous, there was no 14. Here, there was 14th day. Okay. Here we took 0.5 ml on deltoid or anterolateral thigh in case of children. Deltoid in adults. So 0, 3, 7, 14, 28, 0.5 ml intramuscularly. That is about the active immunization. Then come the passive immunization, means we give immunoglobulins. There are actually two kinds of immunoglobulin available, that is HRIG and ERIG, that is human recombinant rabies immunoglobulin and equine rabies immunoglobulin. This is a case of this is a while showing a human rabies immunoglobulin. It is vial contained 2 ml. Each ml is 150 international units. You can see here each ml is 150 international unit. Each ml is 150 international units. So one vial contains 300 international units. Okay, one vial is 300 international units. Because per ml 150. So here is 2 ml. So 300 international units. So we normally we use human HRIG, which is we need 20 international units per kilogram. For ERIG, we need 40 international units per kilogram. See here, one important. If you take this immunoglobulin, you administer as much as immunoglobulin you around the wound area. Okay, if possible, you administer as much as, if possible, you give maximum, if it is feasible. Remaining, you should give from a site away from the wound. Okay, because it may cross react. So in this case, I have given it in the deltoid. If rabies immunoglobulin are not available at present, what will you do? Don't worry, you have a time period of 7 days from the date of vaccination. From at that time only you can ample time for vaccination of passive vaccination of immunoglobulin. But the active vaccination should be given at prompt time also. We should not delay it. Okay. Next, another question arises. If sufficient immunoglobulin are not available at time, what do? You take whatever immunoglobulin you have in your hand, you just dilute it to 2 to 3 fold and inoculate total area. Don't go for any other site. Maximum inoculation that area itself. If at all you require a suturing, what will you do? You use a simple suture and we give antibiotics and TT. You give tetanus toxoid immunoglobulin, TET-glob immunoglobulin. Okay, it's very important. Okay. Can we discontinue the vaccine? We are told that if it is intramuscular, it is 3, 0, 3, 4, 7, 14, 28, 5 dose. In between, can we discontinue? Yes, you can. If the suspected animal is vaccinated following observation for 10 days, animal seems normal. Don't stop the vaccine. You continue the vaccine, and if in between you see that on the 10th day the animal is normal and it is fine, you can discontinue vaccine. Or you can discontinue if the killed or found rabies negative by a WHO recognized laboratory. If the dog is found rabies negative by authorized approved WHO recognized laboratory, then you can discontinue vaccines. A question arises that what if the person who is previously vaccinated bitten by a dog? If I am vaccinated, I am bitten by a dog. Should we vaccinate it one more? Or should we give immunoglobulin one more? You can do one thing. You can do a short rabies post-exposure prophylaxis of previously vaccinated cases. In such, there are two types of cases. One is one dose should be given on day 0 and day 3. Okay, that is you can give IM 0.5 ml or you can give intradermal 0.1 ml on 0 or 3 day, 0 and 3rd day. Second type is 4-site intradermal on same day visit. In the same day itself, you give 0.1 ml intradermal, 0.1 ml intradermally on both deltoid and both thighs or suprascapular. 4-site intradermal. Another question we have is, if I work in a laboratory like lab handling viruses, in such case what you do? We can go for pre-exposure prophylaxis. There is an option for pre-exposure prophylaxis. Okay, don't worry. We have pre-exposure prophylaxis. In pre-exposure prophylaxis, we do that we can take intramuscular or we can do intradermal. If it is intramuscular, it's 0, 7, 21, 28. In intradermal, we give 0.1 ml on 0, 7, 21, 28, but it is 0.1 ml. Intramuscular, it is 0.5 ml. That's the difference. Who all should take the vaccine? Mostly the lab workers working in the with the virus, veterinary surgeons, and people visiting the rabies prone area. 0, 7, 21, 28, 0.5, and 0.1 ml. The previous vaccination schedule was 0, 3, 7, 28. So for lab and vaccine producing workers, what do? You screen the blood titer every 6 months. Every 6 months, check antibody titer. If falls below a zero point 0.1 international units, give a booster. Okay. Similarly, in veterinary surgeons and animal handlers, you check every 2 years. And if the titer go below 0.1 milligram international units, you give a booster. Okay. If in monoclonal antibodies, we give that 3.33 international units per kg. There is one ampule containing about 2.5 ml, which is 100 international units per ml.